Good morning, everyone, and a good evening as well to those that are in the US. This is Suzanne Barnett, and I'm here to facilitate your second presentation in the SNP Learning Series, Phase 2 SNPs. Today, I'd like to just go straight in and introduce your speakers to you. Before I do that, however, can I just make sure that everybody can hear me perfectly fine, and you can tell me that you can hear me just by putting your hand up. You have a virtual hand, and if you just press that, thank you very much for those of you that have done that. Those of you that haven't, if you can't see the hand, you'll see a red button with an arrow on it pointing out to the left. If you press that, you'll see what we call a control panel, and you'll be able to press the hand button. Okay. If anyone's got any problems with anything, please just write in the question box that you've got some problems. And also, this is your opportunity to ask lots of questions. So as the presentation goes on, do type those questions in the question box, because we will actually be taking questions at the end of the presentation. So the other thing I would suggest that you do is, if you have any other applications on, any other windows on, just to shut those down. It makes the quality of your broadcast much better for you. So today I'd like to introduce you to our three speakers. Sterling Hill. She was a successful businesswoman for many years, until 8 years ago when she became ill with clotting issues. She went from physician to physician, but her condition progressively deteriorated. She lost everything. As traditional medical thinking was failing, she reached out to alternative medicine community and the work of Amy Yesko, PhD, and Dr. Ben Lynch, and discovered the world of epigenetics. She learned the basis of her clotting issues resided in the methylation cycle. After regaining her life from treatment, Sterling realized that the medical and lay community knew little of epigenetics and nutrigenomics. She realized that these subjects were of vast importance to the health of everyone on the planet, often being one proverbial stone that was left unturned in chronic illness of any type. As a result, Sterling started MTHFRsupport.com to learn and share the knowledge of genetic polymorphisms and their effect on health. Her passion is to educate the world of the true root cause of chronic diseases and link expert health care providers with those in need. From her adversity, Sterling Hill has become one of the greatest patient advocates of our time, consistently counselling patients about their SNPs and teaching healthcare providers the importance and methods of nutrigenomics. Carolyn Ladowski is the founder of MTHFR Support Australia. She is an ND, herbalist and nutritionist who has a Bachelor of Herbal Medicine, Bachelor of Naturopathy, Advanced Diploma of Naturopathy, and Diploma of Nutrition. Also having studied courses in genetics at Duke University and the University of Maryland in the US. Carolyn became interested in methylation health issues when she noticed that some of her patients were just not getting better despite known and trusted protocols. She began to delve further into the MTHFR gene and discovered that by addressing methylation and genetic polymorphisms, her patients started to improve. Some reacted very quickly, and those who had chronic disease for many decades started to improve where they never had before. She now uses genetics and nutrigenomics as the basis of her approach to better health. Carolyn's knowledge of the biochemical pathways in the methylation cycle is unique, and this is what gives her the edge in addressing chronic health conditions. Carolyn is a regular speaker at MTHFR events and provides both patient and practitioner training through her many webinars, presentations, and online learning environments. Cynthia Smith has developed a passion for functional medicine, clinical nutrition, and genetics nutrigenomics. Her desire is to assist individuals with complex conditions that have been recalcitrant to traditional forms of therapy. She utilizes nutrition, genetics, and comprehensive health history. She is also familiar with interpreting medical testing, Genova diagnostic testing, neurosciences testing, Cyrix testing, immune system testing, and many others. She also has a wide breadth of knowledge of supplements, herbs, glandulars, and the various companies who make and sell them. So today, each of these presenters will be speaking for you on their given topic, and we'll start with Sterling today. So Sterling, if you'd like to carry on with your part of the presentation, that would be great.
Cynthia.
Okay.
Cynthia, my apologies.
Do you want to? Oh, there it is. Okay. So this is a recap of last week. Last week we talked about phase 1, liver detox enzymes, which are primarily the cytochrome P450 families that we discussed. Phase 2 is a little bit different in that the enzymatic reactions in phase 2 are categorized as a glutathione conjugation, and there's many types of there's many SNPs that relate to glutathione conjugation, acetylation, glucuronidation, amino acid conjugation. Primarily it's taurine and glycine, but some of the other amino acids are used as well. Sulfation, and then the big one is methylation. So today I think we're going to divert methylation to another class because it's so lengthy, and we're going to focus on the other phase 2 reactions. Now, recall from last week that the toxic chemicals that enter our body are generally fat soluble, which means or oily solutions and not water. So this makes it difficult for the body to excrete. Therefore, phase 1 acts to create a less fat soluble molecule by converting it to an intermediary metabolite, which oftentimes can be toxic. So you want them quickly to be converted into a water-soluble excretory derivative in your phase 2. It's very important that your phase 1 speed and your phase 2 speed are equalized, or else these intermediate metabolites can build up and escape and can cause oxidation, can stimulate estrogen receptors, and so on and so forth. You'll notice here in this picture that there are quite a few nutrient cofactors that are needed for these enzymes to work. So that's why we suggest people taking vitamins and minerals and things like that and working on their Krebs cycle, because these are the things that the enzymes require to do their job. The next slide is my rendition of the phase 1, phase 2 liver detox, and I've actually listed some of the enzymes that you'll see in your variant report, and these are the enzymes we'll be discussing tonight. In more detail, on the next slide, you'll see the list. And so we'll be going through these one by one. Sterling will give you a high-level overview, and then we'll start, delving into the details. The next slide is an overview list of some of the methylation SNPs. And like I said, this evening we don't have enough time to go through these, but these will be a class unto themselves. And again, there's some more SNPs here. Now, the SNPs that we've listed on this slide and the previous slide are directly related to what we call the methylation pathways, but there's many more in your variant report that we'll be covering in the methylation section. But these are the high-level SNPs that you can see in some of the drawings. Okay, Sterling, you're up.
Hello, everyone. Okay, GGT1, gamma glutamyl transferase 1. Human gamma glutamyl transferase catalyzes the transfer of the glutamyl moiety of glutathione to a variety of amino acids and dipeptide acceptors, and it is present in tissues involved in absorption and secretion. Its main physiological function is to make cysteine available for regeneration of intracellular glutathione and hence to protect against oxidative stress. GGT1 may contribute to diabetes and other metabolic disorders. Serum GGT activity is an independent predictor of morbidity and mortality and increases in obesity and metabolic syndrome. These associations are strengthened by our discovery that SNPs affecting GGT, even at suggestive rather than genome-wide significant levels, include a highly significant excess of those affecting cardiovascular disease and diabetes. Hepatic GGT activity is elevated in some liver diseases. GGT is released into the bloodstream after liver damage, and an elevated level of enzyme may be useful in early sign of hepatocellular carcinoma. GPX3, glutathione peroxidase 3. GPX3 T129C encodes plasma glutathione peroxidase, or extracellular glutathione peroxidase, which functions in the detoxification of hydrogen peroxide. It contains a selenocysteine residue at its active site. The selenocysteine is encoded by the UGA codon, which normally signals translation termination. This gene product belongs to the glutathione peroxidase family and protects cells and enzymes from oxidative damage by catalyzing the reduction of hydrogen peroxide, lipid peroxides, and organic hydroperoxide by glutathione. GPX3 is a selenocysteine-containing antioxidant enzyme that reacts with hydrogen peroxide and soluble fatty acid hydroperoxides, thereby helping to maintain redox balance within the cells. This gene is often downregulated in cancer. Selenium methylselenocysteine has been shown to increase GPX3 expression. GPX3 was found to be downregulated by a high-fat diet and appears to be decreased in human prostate cancers, suggesting that GPX3 may have a possible role in modulating carcinogenesis. GPX3 dysfunction occurs commonly in thyroid, prostate, cervical, gastric, and colon cancers. GSR, glutathione reductase, mitochondrial. This gene encodes a member of the class 1 pyridine nucleotide disulfide oxidoreductase family. This enzyme is a homodimeric flavoprotein. It is a central enzyme of cellular antioxidant defense and reduces oxidized glutathione disulfide, known as SSG, to the sulfhydryl form of GSH, which is an important cellular antioxidant. Rare mutations in this gene result in hereditary glutathione reductase deficiency. GSR includes pyridoxine deficiency and hemolytic anemia due to glutathione reductase deficiency. GSR also maintains high levels of reduced glutathione in the cytosol. Glutathione plays a key role in maintaining proper function and preventing oxidative stress in human cells. GSH is a key cellular antioxidant and plays a major role in the phase 2 metabolic clearance of electrophilic xenobiotics. I'm going to go ahead and add in G6PD, a little bit of information on that with GSR because they link with one another. G6PD is a very important gene with anything to do with glutathione and redox. G6PD in FABism, patients lack glucose 6-phosphate dehydrogenase, an enzyme in the pentose phosphate pathway that reduces NADP to NADPH while catalyzing conversion of glucose 6-phosphate to 6-phosphoglucanolactone. Glucose 6-phosphate dehydrogenase deficient individuals have less NADPH available for the reduction of oxidized glutathione via glutathione reductase. Thus, their basal ratio of oxidized to reduced glutathione is significantly higher than that of patients who express glucose 6-phosphate dehydrogenase. And the reason I add this in is because G6PD, when that NADPH is not produced, is going to affect genes like GSR. A lot of the glutathione genes will show expression. Mutations in GSR may result in hereditary glutathione reductase deficiency, pyridoxine deficiency, hemolytic anemia due to glutathione reductase deficiency. Individuals with pyroluria, hyperoxaluria may benefit from a low oxalate diet, avoiding beans, only consuming natural sources of vitamin C, checking P5P, B6 status, and lysine, and redox signaling to support the NADPH production and the production of glutathione as well. GSS, glutathione synthase. The GSS gene provides instructions for making an enzyme called glutathione synthase. Glutathione synthase participates in a process called the gamma-glutamyl cycle. The gamma-glutamyl cycle is a sequence of chemical reactions that take place in most of the body's cells. These reactions are necessary for the production of glutathione. More than 30 mutations in GSS gene have been identified in people with glutathione synthetase deficiency. Characteristic features of this condition include the abnormal destruction of red blood cells, hemolytic anemia, the release of large amounts of a compound called 5-oxyproline in the urine, and elevated activity in the blood and tissues. Severely affected individuals may also have neurological problems. Again, G6PD would coincide with this gene. Low levels of glutathione affect other chemical reactions in the body, leading to the overproduction of 5-oxyproline. Accumulation of this compound in red blood cells and other tissues causes hemolytic anemia and the metabolic acidosis, and its release leads to 5-oxyprolinuria. Glutathione synthase deficiency is related to an increased rate of hemolysis and defective function of the central nervous system. Its cofactor is magnesium. GSTM1, glutathione as transferase mu1. GSTM1 C5419T encodes a cytoplasmic glutathione S transferase that belongs to the mu class. The mu class of enzymes functions in the detoxification of electrophilic compounds, including carcinogens, therapeutic drugs, environmental toxins, and products of oxidative stress by conjugation with glutathione. The GSTM1 enzyme is biosynthesized in the body from amino acids L-cysteine, L-glutamic acid, and glycine. Glutathione levels may be reduced due to SNPs, lack of one or more of the 3 required amino acids, from poor diet or malabsorption, stress, aging, and toxicity. Proper glutathione levels are also required so that the other antioxidants such as vitamin C, E, selenium, and carotenoids can be properly utilized within the body. Some supplements that may be utilized to support glutathione production are things like curcumin, selenium, milk thistle, vitamin C, vitamin E, MSM, NAC, B vitamins, glutathione cream, oral glutathione, IV glutathione, and redox signaling molecules. Some foods that are great to help boost glutathione are broccoli, cauliflower, milk thistle, curcumin, kale, cabbage, avocado, spinach, onion, watermelon, parsley, whey protein, raw milk, raw eggs, turmeric, red meat, organ meats, and garlic. GSTM3, glutathione S-transferase mu3. GSTM3 V2241 encodes a cytoplasmic glutathione S-transferase that belongs to the mu class. The mu class of enzymes functions in the detoxification of electrophilic compounds, including some carcinogens, therapeutic drugs, environmental toxins, and products of oxidative stress by conjugation with glutathione. Conjugation of reduced glutathione to a wide number of exogenous and endogenous hydrophobic electrophiles may govern uptake and detoxification of both endogenous compounds and xenobiotics at the testes and brain-blood barriers. GSTP1, glutathione S-transferase I1, GSTP1 A114V is expressed in many human tissues, particularly in the biliary tree and renal distal convoluted tubules. GSTP1 is known for its ability to catalyze the conjugation of the reduced form of glutathione GSH to exogenous and endogenous hydrophobic electrophiles for the purpose of detoxification. The GST family consists of 3 superfamilies: systolic, mitochondrial, and microsomal. This GST family member is a polymorphic gene encoding active, functionally different GSTP1 variant proteins that are thought to function in xenobiotic metabolism and play a role in susceptibility to cancer and other diseases. All right, guys. I think Carolyn's next, right?
No, I'll take this one. So Sterling just went through all of the particulars of the various SNPs that are on the variant report, and I want to start with kind of a high-level slide here. Glutathione is made from 3 amino acids, like Sterling said. It's a tripeptide, and so these 3 amino acids have to be present in order for the glutathione enzymes to put the molecule together. Oftentimes people take N-acetylcysteine because that's usually the short, what's a shortage of these 3 amino acids. But I've been seeing a lot of people now who have low glycine, and you'll see that oftentimes in people's blood work when they've got markers for high liver enzymes. And so keep that in mind. It's not always just N-acetylcysteine. Glutamic acid is one I've never seen as being low in people that are having issues with glutathione. Again, it's located primarily in the liver and kidney. It's in its reduced form. That's the quote-unquote good form. The oxidated form is the quote-unquote bad form. And so sometimes people receiving IV glutathione, if they're not healthy enough, that glutathione will become oxidative. Because oxidative stress, it will oxidize, and that's not the form that we want. So be careful with IV glutathione. So let's go to the next slide. So I mentioned how glutathione can be reduced or oxidized, and it's recycled. Overall glutathione levels can be reduced because of SNPs. We know that. Also, stress, aging, and different types of toxicity. When reduced glutathione is converted to its oxidized form, there's a number of enzymes involved in that reaction, and GSSG is one, glutathione disulfide. GSH is another one, glutathione peroxidase. And the input to that pathway is hydrogen peroxide, which is the output of superoxide dismutase. And so we don't have a drawing here, but if you see a drawing, you'll see superoxide dismutase works hand in glove with glutathione. And the whole point of that cascade is to quench reactive oxygen species, sometimes coming from the electron transport chain activity, but sometimes just from oxidative stress. The next slide is a kind of an overview of the things that are cleared by glutathione conjugation. As we mentioned last week, depending on what's coming into the liver, and so these are the things that utilize glutathione conjugation as opposed to, let's say, glucuronidation or methylation. Now, some of these phase 2 liver enzymes have multiple, or some of these enzymes, multiple enzymes will go after a certain type of chemical. So, for example, glutathione contributes to ethyl alcohol breakdown, but there's other enzymes involved in that as well. So some of the xenobiotics that are cleared by glutathione are styrene, so that would be your styrofoam cup, toxic metals, but toxic metals are also cleared through methylation, petroleum distillates, and there's ethylene oxide, and then some of these drugs that are cleared, the big one here is acetaminophen, and I know in the United States it was recommended when my children were babies and getting their vaccines to give them acetaminophen. If a person has SNPs in the glutathione pathway and you give them acetaminophen, you might have some difficulty, so that's not always the best thing to do. And then, of course, penicillin and tetracycline. Some of these endogenous things that are cleared are bacterial toxins, aflatoxins, and like I mentioned, alcohol, lipid peroxides, bilirubin, and quercetin. So some of these endogenous things are made by our own body. So again, it's important that we have our glutathione enzymes supported the best we can. The next slide is just a list of the SNPs associated with glutathione recycling, and Sterling went through that list. This is a little bit more in depth, and some of these slides are going to show you what exactly is the catalytic activity. And you can see here that 5L-glutamyl peptide plus an amino acid equals a peptide, and so that's kind of the chemical reaction. There's actually 3 here that the GGT participates in, GGT1. But the main purpose of this particular enzyme and this cascade of enzymes is to make sure that cysteine is available for regeneration of intracellular glutathione. And as Sterling mentioned, SNPs and GGT, along with many other factors, can contribute to metabolic disorders and diabetes. This next slide are some of the different things that GGT is responsible for, some of the biological processes. Arachidonic acid, metabolic process. Arachidonic acid is one of our fatty acids. Cysteine biosynthesis, regulation of immune system, that's a big one. Xenobiotic metabolic processes, glutamate metabolic process, and the list goes on there. But GGT is part of this cascade of recycling of glutathione.
Okay, so I'm going to have a look at a little bit further in depth of the research, and although we don't find research for absolutely every single SNP that we've got listed on that variant report, there are really quite good studies found on the 5751901 and the 4820599, and there is a link with these two with pancreatic cancer. And it's interesting that in the US, this is the 4th most common cause of cancer in both men and women. And what they've found is that with pancreatic adenomas, generally diagnosed after the cancer has already spread, it would be really good to have some sort of genetic markers that we might look for to prompt us to check for pancreatic sufficiency. And there's certainly growing evidence that suggests that genetic factors are at play with the etiology of pancreatic cancer, and obviously it is familial. But the strongest association was observed for these two SNPs. So why is this significant? Well, the GGT, as Sterling said, is encoded by the GG1 gene, and it's a membrane-bound extracellular enzyme. And it's highly expressed in all secretory or absorptive function tissue like liver, kidney, and pancreas. It's also present in bodily fluids, and serum GGT levels we often look for as an indicator of liver disease or perhaps a marker of excessive alcohol intake. But GGT levels have also been found associated with various other diseases, cardiovascular disease, cancer, and we also look at GGT as a proposed marker of oxidative stress. So the relationship between serum GGT and membrane GGT, we don't really know, but we would hypothesize that if we're seeing serum levels of GGT elevated, then it may well reflect an increased expression of this GGT gene. And as Cynthia has already described, we know that GGT plays a role in maintaining our intracellular glutathione levels, which is critical for phase 2 reactions. And what was really interesting is in the presence of iron and other transition metals, the extracellular cleavage of glutathione by this GGT can actually result in the generation of reactive oxygen species, free radicals, and oxidative damage. So we've got to also be checking, we always say increased iron is a sign of inflammation, but that may well be what the mechanism is. And it's interesting that the overexpression of GGT, the research is telling us, is that it may promote tumour progression and drug resistance by protecting cells from oxidative stress associated apoptosis. A really interesting study I came across it really made me think, because as we've already said, GGT is highly expressed in tissues with secretory function, and this study looked at human body odour and found that GGT is abundantly expressed in our apocrine sweat glands. So perhaps it could even be a key to why some people have body odour. And wouldn't it be interesting if we looked at their glutathione levels and helped with the cysteine and therefore affected their body odor. I do actually have a lot of people who say to me, I've all of a sudden I've got this really bad body odor. I don't know what's happened, and I'm really going to take note now to see if for some reason they'd either stopped their N-acetylcysteine perhaps, or they had they'd increased dosages or something. But it is an interesting thing to consider. All right, Cynthia, that's back to you to talk about GPX3.
Okay, I wanted to mention one thing about the body odor connection. Because glutathione participates in breaking down alcohol, of course, alcohol has other breakdown enzymes. People should notice if their body odor increases the day after they've had a lot of alcohol, because there's a link there. Okay, so now we're going to talk about GPX. This is glutathione peroxidase 3. And you can see the catalytic activity requires 2 molecules of glutathione plus hydrogen peroxide. And then that's broken down. GPX3 breaks it down to glutathione disulfide and 2 water molecules. So that's how you're getting rid of the hydrogen peroxide. It functions, GPS dysfunction, well, because it's located in the thyroid, prostate, cervical, gastric, and it's associated with those cancers. There's an association with these cancers and GPX3 dysfunction, where that GPX3 is not functioning well. It's downregulated. Essentially, though, GPX3 scavenges peroxides, which can damage our tissue. It contains a selenocysteine residue, and so oftentimes people will take selenium to help with their glutathione, even though it's not one of the amino acids. It is a nutrient cofactor. Its distribution is in the plasma, interstitial, extracellular space in the lung and intestine and kidney. The next slide, there's molecular function, glutathione peroxidase activity, selenium binding, and then transcription factor binding. The biological processes, again, are hydrogen peroxide catabolic process, in other words, breaking it down. A response to lipid hydroperoxides and reactive oxygen species. So really, these glutathione enzymes are very important in quelling reactive oxygen species that can not only damage our tissues, but that can also promote tumor growth and things like that.
Okay, so if we look at the research with GPX3, it's when really, as Sterling said, if you're thinking about GPX3, think hydrogen peroxide. And a really good example of this is thyroid function, because antioxidant enzymes like glutathione peroxidases or thyroid peroxidase are upregulated during the synthesis of thyroid hormone. So if the survival of cells depends on the balance between our oxidative stress and our antioxidant functions, it's interesting because glutathione peroxidases are expressed functionally in thyrocytes. And so it's hypothesized that these peroxidases participate in forming like a really complex defense system that maintains normal thyroid function by protecting it from oxidative stress. And hydrogen peroxide that is generated during thyroid hormone synthesis could actually add extra oxidative damage in these thyroid epithelial cells. So it's this GPX3 that really is providing us with this first line of defense against hydrogen peroxide, even before reactive oxygen species enters the cells. And so it's not inconceivable for us to think, well, okay, if this enzyme is down-regulated and we've got a reduced expression of GPX3, could there be a significant effect on thyroid function or even thyroid cancer? And GPX3 in the research is certainly, it's suggested that it directly interferes with thyroid hormone synthesis because it affects the concentration of hydrogen peroxide. This particular study that I've given you the reference for was in a Chinese population, so we don't really know how that correlates to other ethnic groups, but it's a really interesting thing for us to consider. And the GPX3 is really unique because it's the only extracellular isoform that correlates with reduced selenoprotein expression. So I found this quite interesting also because the GPX3 activity have been found in pediatric and young adult arterial ischemic stroke, so AIS. And in 2004, they actually did a study with a GPX3 promoter polymorphism, this particular one, for the downregulation, and it resulted in decreased GPX3 activity. And so because platelet activation and aggregation play a really important role in the pathogenesis of anything like this AIS, and nitric oxide insufficiency we know promotes arterial thrombosis, then it's good to do that relationship between the GPX3 and be thinking, okay, could this also be affecting AIS, cardiovascular? So it was interesting to look further into this GPX3 gene, particularly how it related to the thyroid. Okay, Cynthia's going to talk about the GSR now.
Okay, remember we talked earlier about glutathione recycling, where reduced glutathione is converted to its oxidized form using GS glutathione peroxidase, using H2O2 or hydrogen peroxide. So this is part of the recycling. And you'll notice here again, two glutathione molecules are required, and NADP. NADP is part of what Sterling was referring to earlier, where you have to, well, let me rephrase that. part of the function of this enzyme requires that your Krebs cycle function is good. And included in that Krebs cycle function, or one of the outputs, goes to something called the pentose phosphate pathway. And so this is all related. But notice how it's binding as a cofactor 1 FAD per subunit. So again, we have to go back and refer to the Krebs cycle, and it gets even more complicated because the Krebs cycle, again, depends on vitamins B1, B2, B3. It doesn't work well in the presence of heavy metals. You have to have healthy mitochondrial membranes and so on and so forth. So these things are all related, but glutathione reductase is part of the recycling of glutathione. The ratio of GSSH and GSH is key when determining if you're maintaining oxidative balance. In other words, do you have too much reactive oxygen species, or are you balancing that out? Are you recycling the glutathione and taking care of the oxidative stress? Mutations in GSR can result in glutathione reductase deficiency, a hemolytic anemia, and as Sterling mentioned, there's a link to G6PD here as well. So I wish I'd done another drawing here to show how these things link together, but suffice it to say, glutathione works hand in glove with some of the other pathways in our body to reduce oxidative stress. This is a recap. It's a central enzyme. GSR is a central enzyme of cellular oxidative defense, and it reduces oxidized glutathione disulfide. So that's the oxidized. It's the recycling. Again, the ratio is important when you're trying to determine if oxidative balance of the cell is maintained. This slide, it talks again about the link to G6PD. It's also called favism because of the bean, the fava bean. A lot of people who have a G6PD deficiency react strongly to fava beans, along with many, many other foods. They could be doing just fine and then eat a food or do something that triggers this G6PD, and then the entire cascade starts to fall apart. That includes release of iron, the lysing of cells, and then the pentose phosphate pathway is affected, glutathione is affected, and it goes on and on. It's a cascade. So people with G6PD SNPs, not only do they have to avoid these food triggers, and there's a real good website. We could put that in a note somewhere later if people are interested, but there's a very good website about G6PD enzymes, and if you do have those, you have to be mindful of your glutathione enzymes as well, because they do interlink. And then here's the link about the G6 glucose 6-phosphate dehydrogenase deficient individuals have less NADP, so that the G6PD causes that, and then you've got then you're losing one of the cofactors, the NADPH, needed for this glutathione, this GSR enzyme to work. Here's a list of some of the biological process: cell reduction, homeostasis, glutathione metabolic process, reactive oxygen species, transcription initiation from RNA polymerase II promoter, and then the cellular components. These are just places where the GSR enzyme is acting, in the cytosol of the cells, the external side of the plasma membrane, extracellular exosome, and the mitochondrial matrix, which is extremely important. The link between GSR, SOD, G6PD, the Krebs cycle, superoxide dismutase is here in the mitochondrial matrix.
Okay, as far as the GSR SNPs, there's not a lot of research specifically on these. However, there was a link to lupus in an African population for this first one, 2551715. And last year, Zhang did an interesting article that identified new oxidative stress markers that he called advanced oxidation protein products. And he actually found that these were predictive for anemia and that oxidative stress he particularly saw this in kids that were infected with malaria. And he looked at these polymorphisms, and as Cynthia just said, looking at a combination of different genes in the glutathione SNPs, but also, and predominantly it was the GSR that he found. So now if we look at the glutathione synthetase, Cynthia.
Okay, so here in the catalytic activity for glutathione synthetase, you can see again the Krebs cycles involved, right? You see ATP is required for this pathway, as well as cysteine and glycine. So again, the Krebs cycle, it's very important to have mitochondrial membrane health and make sure the Krebs cycle is being optimized with vitamin B1, B2, B3, making sure that the fatty acids and the amino acids are sufficient to keep that Krebs cycle going. GSS participates in the gamma glutamyl cycle, which Sterling mentioned. And again, it's a sequence of reactions. Magnesium is very important to this particular enzyme. And there's been more than 30 mutations in GSS that have been researched and noted in people with GSS deficiency. Again, we have the abnormal destruction of red blood cells, and that links us back to G6PD. And also elevated acidity in the blood, so metabolic acidosis. But most of the mutations in this particular in GSS deficiency involve just a simple change in one amino acid. This next slide, again, for all of these, we tried to put what the molecular function is and what the biological processes are. And each one of these, if you get on the internet and type in GSS ATP binding, you'll get a whole lot of research. Same with all of these. Each one of these is linked to research. So the molecular functions are the magnesium ion binding, right, because magnesium is needed, glutathione, glycine, ATP binding, and glutathione is involved with aging. So people who don't do well with their glutathione recycling and creation could have problems of aging more rapidly because their cells are undergoing more oxidative stress. And then there's a couple more things on here: response to amino acids, xenobiotic metabolic process, things like that. But these are all linked to research. If you go to the Uniprot website, you can pull these up, and each one, like I said, has linked to its own research.
So speaking of research,
Carolyn?
Yep. So speaking of the research, the glutathione synthetase, as Cynthia just said, it participates in what we call the second step of glutathione biosynthesis. And the mutations of the GSS gene will cause GSS deficiency. And as everybody has said, hemolytic anemia, 5-oxoprolinuria, and there was a study done with small cell lung cancer, and they found that the varied activities of this gene really do impact glutathione enough that it would actually affect the efficacy of chemotherapy agents and patient survival. When it comes, you can see with the A5997G, there is an association with COPD. And when it comes to chronic obstructive pulmonary disease, we know that DNA repair systems are really critical. They play a critical role in protecting our genome from insults caused by our environment. or particularly in smoking. But it's interesting that not all cigarette smokers will go on to develop COPD. So it really does make sense that genes play a part in the development of the disease, and that's why they specifically looked at these SNPs with COPD, because it's glutathione that holds a really important role in protecting our lung epithelial cells from injury and inflammation following any particular insult. I mean, it may be smoking, it may be we're living in a very polluted suburb. And so our antioxidant expression in the lung is really important, particularly if this GSS is reducing overall glutathione levels. And this glutathione synthetase is really the key one that plays a role in lung cell reactive oxygen species. So GSTM.
Okay, GSTM, glutathione transferase mu1. These different symbols after the glutathione transferase mu1, S1, P1, those indicate what part of the body the glutathione enzyme is active. This one encodes the cytoplasmic glutathione S transferase, and it detoxifies electrophilic compounds, including carcinogens, therapeutic drugs, environmental toxins, and of course, as we keep mentioning over and over again, products of oxidative stress. SNPs in GSTM1 may result in the lack of one or more of the 3 required amino acids. Stress, that's actually not worded properly. So you can have SNPs in GSTM1 and have issues, or you can have perfect enzymatic building of glutathione with GSTM1, but if you're missing one of the 3 amino acids, it will act like it has a SNP in it. It won't function very well. So conditions associated with low glutathione include autoimmune disease. And one of the things I do with a lot of my clients who are on, I call it the autoimmune spectrum, because by the time you fall into the disease bucket, you've already been on the spectrum for a while. One of the things that we do with people that have autoimmune conditions, besides vitamin D, is increase their glutathione levels using a transdermal cream rubbed on the arches of the foot before bed to try to get that glutathione level to come back up, because really low glutathione levels are intimately connected with autoimmune diseases. And there's notes here about where TH17 becomes upregulated. So you can address autoimmune disease. One leg of, or one component of that is you're making sure your glutathione levels are adequate. Here's the list of the biological processes. Again, these are all associated with research. If you go to the Uniprot website and type in GSTM1, you'll get that list. GSTM3, here again, it's mu3, that's the brain. This governs the uptake of and detoxification of both endogenous and xenobiotic compounds at the testes and blood-brain barrier. Research has noted, and we've got some citations here, that glutathione as transferase mu3 is downregulated in renal cell carcinoma. And then there's also a comment here about a particular variant, the RS1332018 genetic variants predispose a person to downregulating the GSTM3 expression in the kidney, which could facilitate the carcinogenesis.
Okay, so I'm going to talk a little bit more about that. And although you can see a lot of these, we didn't find any specific research on each of these individual SNPs, there's actually hundreds of studies on the GSTM. And these GST genes, as everyone sort of intimated it, they're grouped into 7 families. That's why you keep seeing different. So there's GST alpha, mu, mu, pi, pi, sigma, omega, theta, and zeta. And the theory is that these have really arisen from a common ancestor, and they've just been reshaped by gene duplication, recombination, and basically an accumulation of a lot of different mutations. So in view of the importance of these GST SNPs in cellular detoxification, particularly in cancer, these SNPs are actually, that's why there's so much research, because epidemiologists are really looking into this in respect to cancer. And they looked at all the literature just up to 2004 and found more than 500 studies of this GST gene and how it related to all cancers, anything from breast, lung, colon, brain. And there is definitely, you'll see in the research that some of these are called a deletion rather than a mutation. And the wild type is normal or increased GST enzyme activity. And that's the one that's probably, they're the ones that are going to protect us more from DNA mutations. The homozygous, though, particularly when this is combined with the GSTT1, and that's certainly, there's the link to have a impaired ability to eliminate carcinogenic compounds. And so probably they suspect that the GSTM1 homozygous individuals are probably more at risk of getting cancer. But again, we need to look at all these genes and consider the cancer risk, because we need to look at the GSTT and the GSTP as well. And this last one really, quite an interesting article that looked at the GSTM3 and its relationship with Helicobacter pylori, and found that when this gene is downregulated, it was associated with an increased risk of Helicobacter pylori. As far as Alzheimer's disease, it was linked with late onset and mild cognitive impairment, particularly in women. And the brain is known to obviously show high oxygen metabolism and sensitivity to oxidative stress. And this particular SNP is most abundant in liver, muscle, and brain. So that makes sense. And it's because that this brain-specific GSTM3 co-localizes with the amyloid beta plaques. So that there is that association. So I thought that was quite an interesting study. GSTP1, Cynthia.
GSTP1 glutathione transferase pi1. This one, pi1, is found primarily in the biliary tree and the renal distal tubules. This slide again is a list of biological processes. You can read that, but I wanted to there were some other things about this I thought were important to talk about. This one is in many, this particular GSTP1 is in many tissues, more than some of these other ones. This one has been linked to breast cancer carcinogenesis, and they're actually looking at it now as a specific tumor biomarker, breast cancer tumor biomarker. That's all I'm going to say about that. The rest is on the slide, talking about the biological process. There is a cellular, this is interesting, there's a cellular response to lipopolysaccharides, and as you know, lipopolysaccharides are something that are often elevated in people with leaky gut, antibodies to these lipopolysaccharides. So that's something to keep in mind too. And that's really about it. The rest is, you can just read the slide.
Okay, so if we look at the research, this first one, the 1138272, they looked at a Russian population with vitiligo, and it was really interesting because this T allele was really associated quite convincingly with vitiligo. And it's thought that this whole detoxification system defect, predominantly the xenobiotic metabolizing genes and oxidative stress, was the cause. And it really is that this GST, the repressed level, may result in a deregulation of the cytokine-mediated keratinocyte-melanocyte interaction, because there is this disturbance in redox control. And they also linked this chance of vitiligo with the GSTT1 and GSTM1. So these three SNPs, the GSTT1, GSTM1 and the GSTP1, obviously work in unison. Secondly, there was a relationship between air pollution exposure, kids with one or more of the 1138272 and recurrent asthma. There was also a relationship between key genes GPX1, which is the 1695 RSID, GSTP1, which is the 1138272, and as Cynthia said before, MNSOD works very closely with these two genes, the 4880. Now, if you remember, MNSOD, manganese superoxide dismutase, which we also call SOD2, is a mitochondrial enzyme, and so it plays a key role in protecting cells from oxidative damage. So always make sure that you're looking at your SOD2 in relationship to these glutathione genes as well. And certainly there's been a lot of studies about cancer and this particular gene. And there was one here that, if you're interested, with the elevated PSA level, again, due predominantly to severe inflammation of the prostate, because there's just not enough antioxidant systems. And with cancer, there's one of the main mechanisms they believe is that when you've got malignancy and inflammation, it's all about oxidative damage. And there's a lot of evidence that points to a role for DNA damage in carcinogenesis caused by excessive reactive oxygen species. And we know that if you've got increased ROS, then there can be certainly an increase in concentration and or a decrease in antioxidant defense mechanisms. So that makes sense, particularly when you've got environmental factors that might add on to this, like inflammation, diet, lifestyle, and that will increase our risk of breast cancer or any sort of cancer. So if we look at the clinical pearls, and I'm sure Cynthia will add more to this, as Sterling said, there's some key foods that we can certainly boost glutathione levels. Obviously best from fresh foods, but all our brassica type family, broccoli, cauliflower, cabbage, spinach, onion, and milk thistle we know is a great support for liver, as is turmeric. It's a great anti-inflammatory. And you'll also see obviously anything that promotes our folate levels, our kale, our leafy greens. Parsley is a great detoxifier, as is, I was trying to think of the herb that my husband hates. I don't know, I'll think about it. They use it a lot in Asian cooking. Coriander. He absolutely hates coriander, but in the US you call it cilantro, I think. And as Sterling said, raw milk, raw eggs, all of these will support glutathione synthesis. The supplements that we might use, certainly turmeric, curcumin, selenium, silimar and vitamin C, E, MSM, because it's a great sulfur producing amino acid, NAC, which is the N-acetylcysteine, all our B vitamins, our minerals. Now, just a word on glutathione. I probably have a bit of a different view to a lot of other people with how I use glutathione, and I never go straight into glutathione because I think we have to make sure when you look at how glutathione is regenerated, outside the cell, it actually comes into the cell to detoxify and get rid of its it becomes oxidized. And inside the cell, it needs the regeneration of selenium, zinc, and cysteine to reduce it, to make it into the good form. So if you're using glutathione cream or any glutathione straight off without the ability to reduce it, you're going to end up with more oxidized glutathione. So I tend to start with the cofactors required to reduce it before I introduce glutathione. I never go, and many of the practitioners out there will probably know that if you give someone that's very sick glutathione cream, or any sort of glutathione, they often get worse. Specifically, GGT1, have a look. Is it elevated? Do we have elevated serum GGT? Should you perhaps be checking for pancreatic function? Should you check for cancer markers? And obviously, we need to support liver function. GPX3, really think about selenium because it is a selenium-dependent enzyme. Check levels, check thyroid levels, check for cardiovascular risk factors. GSS cofactor is magnesium, so we've got to make sure that there's sufficient magnesium. Don't forget, magnesium is used in over 300 metabolic processes every single day. So if someone is very stressed, there's going to be a high demand for magnesium. GSTM, cysteine is important, so N-acetylcysteine, we all know that that's great for regenerating glutathione. And obviously we have to make sure that the environment, the diet and the lifestyle are sufficient, that people are not creating more reactive oxygen species than the body can cope with. Okay, so Cynthia, if you want to start with acetylation.
Okay. One of the things I wanted to mention about the glutathione cream is that sometimes it's best to start, like you said, with the foundational, the minerals, the B vitamins, and then layer things in one at a time. But the layering and the order have to do with a person's health conditions, have to do with their SNPs, things like that. And that's something we're going to talk about at the very end of this series. Okay, so acetylation, the thing that's important about acetylation is its conjugation with an acetyl-CoA molecule. And oftentimes you see people who have an inability to tolerate sulfa in their acetylation pathway. This particular enzyme, this particular reaction, this acetylation reaction, is dependent on thiamine, pantothenic acid, and vitamin C. So again, there's nutrient cofactors that are associated with the NAT1 and NAT2 enzymes. This is a big one for detoxifying environmental toxins and, of course, cigarette smoke and exhaust fumes and things like that. So people who have SNPs in the acetylation pathways really need to be careful with smoking. We have a note here that both slow and rapid acetylators are at increased risk for toxic overload if they're exposed to some of these environmental toxins that happen to be phase 2 detoxified through these acetylation enzymes. The two SNPs, oh sorry, that's Sterling, go ahead. Sterling?
Hello. Yeah, I'm here. Sorry, it took me a minute to unmute it. NAT1, okay, N-acetyltransferase 1 protein. Is the NAT1 or 187Q is a phase 2 xenobiotic metabolizing enzyme involved in the biotransformation of many aromatic amines and heterocyclic amines. NAT1 metabolizes drugs and other xenobiotics and functions in folate catabolism. Many drugs and chemicals found in the environment, such as those in cigarette smoke, secondhand cigarette smoke, carbon fuel emissions, and burnt charcoal meat, can be either detoxified by NATs and eliminated from the body or bioactivated to metabolites that have the potential to cause toxicity and cancer. NAT1 has been implicated in some adverse drug reactions and is a risk factor for several different types of cancers. Hydrazine sulfate is a chemical used in industry and as jet fuel. And ironically, it's also used for cancer treatment in certain cancers. Some of the cancers are colon, rectal, lung, brain, Hodgkin's, and a few other cancers that hydrazine sulfate is used in. This drug right here, hydrazine sulfate, may block chemical reactions in the body that might lead to the malnutrition and muscle wasting. NAT1 affects the growth and drug resistance to breast cancer cells. NAT2, also known as N-acetyltransferase 2 protein. NAT2 is a phase 2 xenobiotic metabolizing enzyme involved in the biotransformation of many aromatic amines and heterocyclic amines. It also catalyzes the N or O acetylation of various arylamine and heterocyclic amine substrates and is able to bioactivate several known carcinogens. This gene detoxifies hydrazine and arylamine drugs. NAT2 metabolizes drugs and other xenobiotics and functions in folate catabolism. N-acetyltransferases are enzymes acting primarily in the liver to detoxify a large number of chemicals, including caffeine and several prescribed drugs. The NAT2 acetylation polymorphism is important because of its primary role in the activation and or deactivation of many chemicals in the body's environment, including those produced by cigarettes as well as aromatic amine and hydrazine drugs used medicinally. In turn, this can affect an individual's cancer risk. Individuals can be classified as either rapid or slow metabolizers. In general, slow metabolizers have higher rates of certain types of cancer and are more susceptible to side effects from chemicals metabolized by NAT2. Many drugs and chemicals found in the environment, such as those in cigarette smoke, secondhand cigarette smoke, carbon fuel emissions, and burnt charcoal meat, can be either detoxified by NATs and eliminated from the body or bioactivated to metabolites that have the potential to cause toxicity and or cancer. NAT2 has been implicated in some adverse drug reactions and is a risk factor for several different types of cancers. NAT2 has been shown to play roles in the catabolism of folate, which is required for the synthesis of S-adenosylmethionine, the methyl donor for cellular methylation reactions. Cynthia and Carolyn, back to you.
Okay, the next slide is an example. I like this slide because it talks about, you can see the interlink between these various enzymes. So arylamines used to be chemicals that they would put in women's hair dye back in the 1980s until they realized that it's a carcinogenic compound in some cases. So this particular slide, I need to blow mine up here. This particular slide relates to bladder cancer. You can see the detoxification of the arylamine using the CYP1A family, cytochrome P450, phase 1 liver. And then you can see it's converted to hydroxyarylamine, and then glutathione acts on it to make it non-reactive. Now for the arylamine, NAT2 acts on it to make it non-reactive. That's in the liver, and then you see the arrow going through the blood urine to the bladder epithelium. In this case, hydroxyalamine is acted on by NAT1, and it's converted to NHCOCH3 and then that's acted upon, or that's converted to a DNA adduct chemical that contributes to the pathogenesis of bladder cancer. This is highly expressed in the liver, NAT1. I think in this case the CYP1A is the 1A2. There's a nice citation associated with this slide if you would like more information. There are certain things are cleared by acetylation. We probably should have reversed those two slides. There's a few xenobiotics, but a lot of drugs are cleared by acetylation, and you can see the list there. Endogenous things that are cleared by acetylation, meaning our body makes them, are serotonin, histamines, tryptamine, caffeine, choline, tyramine, coenzyme A. And the nutrients that are needed for this enzyme to work properly, the list is pretty extensive. CoA, because that's its central molecule, but molybdenum, iron, vitamin B3, vitamin B2, vitamin C. So again, with any approach that you would take when you're dealing with SNPs is make sure a lot of these nutrient cofactors are layered in, and the speed at which you layer them in depend on the person's SNP and health history, but you layer them in. Okay, the catalytic activity for N-acetyltransferase 1 is acetyl-CoA, and it takes up an arlamine and converts it to CoA and an acetyl-arlamine. It activates and deactivates hydrazine drugs and arlamine drugs. Hydrazine is also used, and Sterling mentioned this, hydrazine was a fuel used on the thrust vector control of the space shuttle, which was associated with the solid rocket motors. And people who worked around hydrazine developed cancers at an increased rate. And it probably related to this particular enzyme SNP. This was years ago before I really understood what the polymorphisms were, but there was a higher incidence of cancer with these men who worked around this solid rocket motors. So if you look at NAT1, if you do some research on NAT1, you see that it's broken down into all kinds of combinations, and they'll name the combinations differently. NAT, if you're whether you're a slow metabolizer or a fast metabolizer, is determined on the SNPs that you have in these various RS numbers. So, for example, if you're a slow metabolizer or slow metabolizer phenotype, you have to have 2 slow metabolizer alleles to be considered a slow metabolizer. If you're a fast metabolizer or rapid metabolizer, you only need 1 rapid metabolizer allele. But either way, fast or slow comes with issues. This particular enzyme, NAT1, detoxifies drugs and chemicals found in the environment, cigarette smoke, secondhand smoke. Sterling went through all of this already. NAT SNPs have been implicated in adverse drug reactions. And again, there's mention here of hydrazine sulfate, which is cleared via acetylation. It's used in industry and as a jet fuel and also on the space shuttle. And it's a basis for medication as well for different types of cancers, colon, rectal, lung, brain, Hodgkin's, and other cancers. There is a phenomenon with hydrazine sulfate in that if the levels get too high, it could lead to malnutrition and muscle wasting. N-acetyltransferase 2, a very similar catalytic activity. You can see the acetyl-CoA is required. Again, there's a list of things that these SNPs have been associated with. reactions to sulfonamides, reactions to codeine, Zoloft, methadone, and the list goes on. Also acetaminophen. NAT2 has been shown to play roles in the catabolism or the breakdown of folate, which is required for the synthesis of SAMe, which is our body's major methyl donor. And so this not only is a phase 2 liver detox enzyme, it also plays a role in these methylation pathways that we're going to be discussing in a couple of weeks. Carolyn?
Okay, so I'm not going to spend too much time on this, but you can see down the bottom there, Cynthia was talking about slow and rapid metabolizers, and we've got to be very circumspect when we look at some of this research, because there is a huge difference across different ethnic populations. So in general, the slow metabolizer is most prevalent in the Northern African and Scandinavian, up to 80%, and the lowest is in the Canadian, Eskimos and Japanese, whereas intermediaries are seen more in the Asian populations, Chinese, and 40 to 60% of African Americans and most non-Scandinavian Caucasians are slow metabolizers. As far as the research goes, it definitely is associated with higher cancer incidence due to its inability to break down a lot of these known carcinogens. The 4986782 is associated with a higher frequency of smoking-induced lung cancer, head and neck cancers. So as both the ladies have said, smoking with this particular genetic polymorphism is really not a great idea. You can see there that this NAT2 upregulates gene expression, being associated with a risk of bladder cancer. The NAT2 C481T was increased risk of adverse reactions to anti-tuberculosis drugs in Black South Americans, and NA2G191, we didn't find any specific research. In the NAT2, again, you can just see a lot of association with cancer, and there's the disparity too amongst different ethnic populations is really important to have a look at. So if you are in certain regions, it's probably a good idea to look at the research because they do differ quite significantly. All right, on to glucuronidation.
Okay, glucuronidation is our third primary pathway in phase 2 liver detoxification. In this case, the glucuronidation enzyme covalently links UDP glucuronic acid to a xenobiotic or endobiotic to make it water soluble. And then again, like many of these other phase 2 liver detox molecules, they're removed from the body through urine or through bile. The directed excretion of glucuronides from the lumen of the endoplasmic reticulum to the plasma membrane and the exterior of the cells is an important regulated process. Impaired excretion leads to liver damage. Specific transporters for excretion of glucuronides have been implicated in liver cell function in the endoplasmic reticulum and in the bile. There's prescribed drugs that we're going to talk about later are detoxified through this pathway. So we'll go through the list, but it's pretty extensive. There's a syndrome called Gilbert syndrome, and people that have this syndrome will generally present with elevated serum bilirubin levels. They'll chronically be higher than normal, and it's associated with SNPs and glucuronidation pathway. there's certain things that can increase the activity, certain foods, and there's a list here: citrus peel, dillweed oil, caraway oil. There are three.
All right. I guess my turn, right?
Yeah, it's your turn.
Okay. UGT1A1, UDP glucuronotransferase 1. UGT1A1 is an enzyme of the glucuronidation pathway that provides instructions for making enzymes called UTP, glucuronosyl transferases. These enzymes perform a chemical reaction called glucuronidation, in which compound called glucuronic acid is attached to one of a number of different substances. The protein produced from the UGT1A1 gene, called the bilirubin uridine diphosphate glucuronyl transferase enzyme, is the only enzyme that glucuronidates bilirubin, a substance produced when red blood cells are broken down. This enzyme converts the toxic form of bilirubin to its non-toxic form, making it able to be dissolved and removed from the body. UGT1A1 is of major importance in the conjugation and subsequent elimination of potentially toxic xenobiotics and endogenous compounds. Mutations in this gene result in syndromes such as Gilbert syndrome. Irinotecan is a camptothecin analog used as an anti-cancer drug. Severe, potentially life-threatening toxicities can occur from irinotecan treatment. People with certain UGT1A1 SNPs may experience toxicity with this drug. UGT2A1 and 2A2. UDP glucuronotransferase 2A1 and UDP glucuronosyl transferase 2A2. UGT2A1 or 75K encodes a UDP glucuronosyl transferase enzyme of the glucuronidation pathway that provides instructions for making enzymes called UDP glucuronosyl transferases. These enzymes perform a chemical reaction called glucuronidation, in which a compound called glucuronic acid is attached to one of a number of different substances, also found in the olfactory epithelium and brain. Isoform 2 is mainly expressed in the nasal mucosa. UGT2A1 and 2A2 play a role in the olfactory perception and in the protection of the neural system against airborne hazardous chemicals. It is also mainly expressed in the nasal mucosa, and it has glucuronidation activity towards several different endobiotic and xenobiotic substrates. Back to Cynthia and Carolyn.
Okay, so the next slide is a list of drugs that are cleared by glucuronidation. One of the things you'll notice here is that certain drugs, so for example acetaminophen, have multiple pathways that they clear through. We know that acetaminophen is cleared through glutathione conjugation, but it's also cleared through glucuronidation. So there's backup pathways for this. One of the important things to note about glucuronidation is that it helps break down, not only does it help break down bilirubin, but it also helps break down bile, and those two are interrelated. Part of detoxification of your whole body is dependent on, besides phase 1, phase 2 liver detox, but also this recycling of bile. So the bile is made in your liver, and as it's generated in the liver, it carries out some of these toxins, That bile is then stored in your gallbladder, and then when you eat fatty foods, that bile eventually out it goes. It goes out with your stool. Some of it's recycled, but it's a way, it's a vehicle for the liver to get rid of these toxins. Morphine is also on the list. Valproic acid, steroids are on there, but it's a pretty extensive pathway for clearing drugs. And like I said, glucuronidation is a backup pathway for some of these other pathways like sulfation. You'll see that in later slides, and also glutathione conjugation. Now, it's the nutrients that are needed are the B vitamins, magnesium, and glucuronic acid. Okay, Sterling went over a lot of this, but UGT1A1 is found in the biliary tissues, the colon, the intestine, the liver, and the stomach. So again, you can see how it's important for recycling, or breaking down some of the detoxification pathways that we need, or supporting those. It also catalyzes the glucuronidation of 17-beta estradiol and some of these other hormones. Also, naphtenols. There's a list here too about some of the things that are important that are broken down by glucuronidation. The 17-beta estradiol is one of them. Most steroid hormones, though, are primarily detoxified through methylation, sulfation, and then glucuronidation. You can upregulate this UGT1A1 enzyme using sulforaphane, EGCG, and flavonoids. Sulforaphane is a broccoli seed extract, and you'll see that in many of the liver detox support formulas. You'd want to be careful, though, if somebody had CBS upregulated SNPs, and we'll talk about that when we get to the methylation. Bilirubin is cleared through this pathway as well, and some phenols. UGT2A1 is found primarily in the brain, fetal lung, and olfactory epithelium, so the inside of the nose. And then the 2A2 is the colon, the intestine, the liver, and the stomach. Let's see. Biological processes, flavonoid glucuronidation, sensory perception of smell. One of the things you'll see is that these are important for olfactory perception. And Sterling mentioned about the protection against airborne hazardous chemicals. Carolyn?
Thank you. Okay, we better pick up the pace because we're running over time. Just a couple of things that I wanted to highlight here in the UGT SNPs. Obviously, there's quite a bit of association with different various forms of cancer, biosynthesis, and hyperbilirubinemia. So not too much to report, but you can have a look at that research yourself. All right, so let's, Cynthia, let's just go through now the peptide and sulfation a bit quicker, and then I will finish off with the methylation.
Okay, peptide conjugation. Now, there are no SNPs directly in this area on the variant report, but again, it's one of the important pathways. And the key thing to remember here is for these conjugation pathways to work, these peptide conjugation pathways to work, there has to be glycine present. There has to be arginine. So these things have to be there. And oftentimes, when people are having issues with liver detox, it's important to look at a panel to see what their amino acid levels are. There's some research here about people that have hepatitis, or they have alcohol liver disorders, liver carcinomas, toxemia. It's important that their peptide conjugation pathways are running well and are boosted. And again, these amino acids are derived from protein foods, and so one has to have good digestion to get these peptides to the liver where they do their job. Peptide conjugation, phase 2, salicylates of aspirin, nicotinic acid, endogenous. Again, you see how bile acid is also cleared not only through glucuronidation but also peptide conjugation. Nutrients needed, arginase, nitric oxide pathway, glycine, folate, magnesium B1, B2, or sorry, magnesium B2, B6. Bioactive form is P5P. Now this is taurine conjugation, bile acid, lauric acid, butyric acid. Now one of the things that we help people, that we give to people who are having issues with their gallbladder or with their bile, is we give them taurine as an amino acid supplement. Sulfation is the fifth phase 2 liver detox pathway. This is a big one for hormones, also food additives, and lots of drugs, lots of pharmaceutical drugs. This is also the primary route for eliminating neurotransmitters, so during the breakdown of neurotransmitters. A diet low in methionine and cysteine has been shown to reduce sulfation. Sulfation is also reduced, interestingly, by excessive levels of molybdenum or vitamin B6. And so this sulfation pathway becomes something that's in play when you're looking at the CBS upregulation pathway, or people that have issues with methionine and in the CBS pathway. Drugs cleared by sulfation, there's a list here. Notice that some of the endogenous chemicals that our own body makes, like DHEA, quercetin, are bile acids, estrogens, testosterone, cortisol, catecholamines, which are dopamine, epinephrine, and norepinephrine, are broken down in this pathway. And the sulfation, the key sulfation genes that we'll talk about are SULT1C3 and SULT2A1. Sorry, Sterling, that was yours.
Okay. Well, I'm going to also add just a little bit in about the 1A1, even though we didn't put that one up there. Just a little quick over. It's sort of like the 2A1, but I'll add it in anyway. The SLUT1A1, also known as sulfonotransferase 1A1. Sulfonotransferase, it is a sulfonotransferase that utilizes PAPS, which is also known as 3-phospho-5-adenylyl sulfate. And it utilizes PAPS as sulfonate donor to catalyze the sulfate conjugation of catecholamines, phenolic acid, and neurotransmitters. It has also estrogen sulfonotransferase activity, responsible for the sulfonation and activation of minoxidil. It mediates the activation of carcinogenic and hydroxyarylamines to DNA binding products, and could so participate as modulating factor of a cancer risk. Now, the SLUT1C3 sulfonotransferase family, cystosolic 1C member 3, sulfonotransferase 1C3. SLUT1C3 enzyme of the sulfation pathway that is expressed in the small intestine. This enzyme catalyzes the sulfate conjugation of many hormones, neurotransmitters, drugs, and xenobiotic compounds. These systolic enzymes are different in their tissue distributions and substrate specificities. Sorry, tongue-tied there. Now, SLUT2A1, sulfonotransferase family, cystosolic 2A. Sulfonotransferase 2A1 enzyme is part of the sulfation pathway. It aids in the metabolism of drugs and endogenous compounds by converting these substances into more hydrophilic water-soluble sulfate conjugates for excretion. This enzyme is encoded. The enzyme encoded by SLUT2A1 catalyzes the sulfation of steroids and bile acids in the liver and adrenal glands, and may have a role in the inherited adrenal androgen excess in women with polycystic ovarian syndrome. It is present in the liver, adrenals, and at lower levels in the kidneys. I wanted to also add, we've met a handful of people over 40 that have had 3 to 5 homozygous and the SLUT2A1. Every one of them, gallbladder issues, gallbladder removal, that were chronically ill. We know it has a lot to do with bile acids, so I thought that would be a great clinical pearl to add there. Now back to you, Cynthia and Carolyn.
Okay, I'm not even going to go through the SULT2A1 slide, and it's just a repeat of what you said, but I think next Carolyn will be talking about my drawings here and wrap things up as we lead into the methylation section for another class.
Okay, thanks, Cynthia. So here are our key methylation SNPs, and we definitely will be covering all of these in the later sessions. There's a lot to go through and it is quite complicated, so we'll leave that to another time. But just certainly as an overview, many of you will have seen this, just looking at how each of these pathways interact. And in the center you can see your folate pathway here that interacts with the methionine pathway, our CBS, and here we've got our tetrabiopterin and urea cycle. And you can see Cynthia was talking about the Krebs cycle, and this is how it interrelates with this overall pathway. And that's what we refer to as pathway A, B, C, and D. And this is Cynthia's drawing, and really it's important to understand how methionine and this whole cycle interrelates with our liver. And hepatic methionine metabolism is regulated by the availability of our dietary folate. And we know that that appears as 5-MTHFR, and its substrate or cofactor is B12. And this is really important for our methionine synthase enzyme. And you can see that here, the MTR. You'll often see that also written as MS. And it's this methionine synthase interaction that generates methionine, and you can see methionine sitting up here, from homocysteine. And it's the alternate pathway for methionine where choline is the precursor. So you see this BHMT, and that stands for our betaine homocysteine methyltransferase. So these are really important. Now, the MAT gene, MAT, which stands for methionine adenylyl transferase, it adds ATP to methionine for the generation of SAM. So here's our all-important SAM there, S-adenylyl methionine. And MAT1 particularly is expressed in the liver, and it's capable of converting our liver methionine to 6 to 8 grams of SAM a day, and that's pretty significant. So when you see these MAT genes later on, you'll realise the significance of them, not only for liver methylation, but also for our neurotransmitter synthesis. And SAM, as we all know, is our principal methyl donor in methylation reactions, and including our really important DNA methyltransferases. And it's the methyl donation, because SAM is so involved, it converts to S-adenosyl homocysteine, and you can see SOR sitting there, which is the substrate for the reversible SOR hydrolase. So this reaction here between SOR and homocysteine can happen either way, and therefore homocysteine can actually increase SOR. So if you've got a high homocysteine level, it can actually feed back and inhibit SOR. And elevations in liver homocysteine and SOR, together with a decreased SAM synthesis, reduce our SAM-SOR ratio. And SOR levels really closely correlate with homocysteine, and SOR is an inhibitor of methylation. So it's really important to consider this whole SAM-SOR situation, because SAM regulates our total or reduced glutathione. And I'll show you a little bit about that in a minute. And so glutathione is oxidized to its oxidized form, which is the GSSG. And it's the glutathione GSSG, as Cynthia said, it's that ratio that is considered to be an accurate measure of our overall oxidative state. So in addition, SAM provides negative feedback to our MTHFR reaction that converts 5,10-methylene tetrahydrofolate to our active 5-methyl. So really a SAM deficiency is going to have quite a big reaction, and we'll go through this pathway in detail when we cover our CBS pathway. And I put this in because I really like this graphic because it makes it quite simple to understand. We've got methionine being metabolized to homocysteine with the transfer of the methyl group to our SAM, and hepatocytes express our BHMT, and that uses betaine as a substrate. But when we've got increased oxidative stress, homocysteine is actually diverted into the CBS pathway, and you can see this arrow here. So when we've got high oxidative stress, we steal our cysteine from homocysteine to support our glutathione pathway. And so it's really important to, when we're doing this, we're inhibiting methionine synthase. And so we're going to go through this a lot more, but it's just and I didn't put this in your slide, so I'll make sure that you do get an updated, I might just send you this slide because it's really good, and Sterling talked about PAPs down here, and you can see taurine and how these all interrelate. So methionine is such a key critical, or rather our methylation is so key to so much, but looking at our levels of SAM is what determines how much glutathione our liver can actually make. And these are all the drugs that are cleared by methylation, and so there's a lot there that we might be prescribing every day. And by the way, for those in Australia, the acetaminophen is Tylenol, which we don't have here, but just so you know. And then there's all our nutrients. So I think we'll just probably leave it there. We all know our we'll go through this more, but we know the really important functions of methylation, so we have to make sure that we're supporting it at every level. And I think we'll just take questions now. Suzanne?
Okay, excellent. Thank you for a great presentation from everybody. We do actually have quite a number of questions that have come through, so I'm going to start with this one. This is for you, Carolyn. What are some of the signs and symptoms of liver issues in a patient?
Oh, well, there's a lot. Feeling nauseous, even looking at the whites of their eyes to see if they're a bit yellowish. Urine might be, say, quite dark. They might be getting nausea or vomiting or diarrhea, or even bloated abdomen, swollen ankles, abdominal pain. There's so many that we might be looking for in cases of liver function dysregulation.
Okay, thank you. And Cynthia, can you tell me how bacteria, viruses affect liver function?
Yeah. Obviously, there's viruses that affect the liver, right? We have hepatitis and things like that. But as far as bacteria and even parasites, oftentimes, and this is something I see in elderly people, they'll be given an antibiotic for something, and that antibiotic will not only kill the bacteria, but will also kill the bacteria in the gut, both the good and the bad, and whatever bacterial infections they're trying to go after. The resulting toxins from that bacteria need to be cleared through the liver. And so in the elderly patients or people that have liver damage, those toxins aren't going to clear well, and they'll get very sick just from a simple round of antibiotics. In the case of somebody who has a leaky blood-brain barrier, which goes hand in glove with leaky gut, after a certain point, leaky gut comes first, then leaky blood-brain barrier can potentially come much later. These toxins not only have to be cleared through the liver, but they're also circulating up through the blood-brain barrier. But any toxin, whether it's made by bacteria or a virus, eventually makes its way into the liver for clearing.
Super, thank you, Cynthia. I've got a question for you, Sterling. What would you say is the most critical SNP that comes up in phase 2 liver detoxification?
To me, it's GSS and GSR. Reason being, when you connect them with G6PD, which we'll be talking about later, it kind of holds the key to almost everything here. That combination, when you see somebody, for instance, with hemolytic anemia, their phase 1 liver detox, the cytochrome P450 genes are no longer working correctly. Methylation is no longer working. Phase 2 is no longer working. It's a master key. And when I heard everybody's takes on glutathione, let's say you get somebody who's taking in glutathione and they're getting that bad adverse reaction, you've got to go back and look to see if you're oxidatively damaging their glutathione by looking at their genetics. For instance, when we see the GSS, GSR, and G6PD combination, and you're giving somebody ascorbic acid, not natural C's, but ascorbic acid, you could think you're doing good to them, but in all essence, what you're doing is you're actually oxidatively damaging any glutathione they take in. If they have a high diet of beans, which contain quinolonic acid, or they're taking drugs with the word quin, Q-U-I-N, in them, or vitamin K, this could be oxidatively damaging the glutathione that you're putting into them. That is something that wasn't too much talked about, and this is tied into GSS, GSR, and then also G6PD we'll be talking about, which is very crucial, because if that's not functioning, nothing's going to function correctly. You can't fix anything. It completely shuts down methionine synthase and also phase 1 CYPs. So I believe it's crucial.
Great, thank you very much, Sterling. I've got another question here. I'm not sure which one of you is best to answer this. So this is from Jennifer. Can a GSS SNP contribute to a higher anion gap? So who wants to take that one?
Well, yes, I think Sterling already was said that in the beginning, is that you'll get increased acidity, and with an increased anion gap, you're certainly going to have a more acidic patient. Our anion gap really should be sitting between 9 and 12. That's our reference ranges in Australia. And so outside that, I would certainly be saying that we're dealing with a more acidic patient. And we know the more acidic we are, the more likely we are to have inflammation, and our biochemical pathways are not working as efficiently as they should.
Great. And I've got a question here from Michaeline. What glutathione cream do you recommend? I used Apex Energetics cream till I realised that it had some toxic ingredients.
Do you want me to take that one, Carolyn?
Yeah, you take that one.
I personally use Zymogen.
Can I add what I use to raise my glutathione?
Sure.
Redox signaling molecules. The ones that I use have been clinically proven to raise glutathione intercellularly and also superoxide dismutase 500 to 800% for 2 hours after taking them.
Great, thank you for that. And we've got a question here from Scott. There was a mention for G6PD enzyme website reference. What is the website to which you are referring to, please?
That is G6PDdeficient.org. I believe now to get the whole food and drug list on there, you do have to pay, you can pay a lifetime membership, but I think it's under $100 for a lifetime, so it's very well worth it.
Do you think you could repeat that again? And I'll actually type it into the chat box.
Yeah.
Because you actually faded out there a little bit.
Okay. G6PD deficiency.org.
Beautiful. Thank you.
I wanted to add something about G6PD. People that have SNPs and G6PD, if they look back in their history, they might have been anemic at one point, maybe as a child, or at another point they might have had high ferritin levels or high percent SAT, which would be the case if somebody took like a vitamin C IV push. But people with G6PD also have fluctuations in their energy level, but really historically you'll see that their iron modulation capability over the years has not been consistent.
Okay, super. Now there aren't any more questions as such, but we've got quite a few people asking about the handouts. Is it possible to have the slides given as one page per slide?
Yes, we'll upload those to the website this afternoon or tomorrow with the recordings, so they will be able to log into their account and see both the slides as four, the slides individually, and also the recording from today's webinar. I'd also just like to add one thing which we haven't discussed, but it's a really big factor, and it's glyphosate. Glyphosate is it's basically Roundup, and it's used in a lot of crop rotations. It's used in preventing insects onto key crops like corn, soy, wheat. And there's a theory right now, and Stephanie Seneff has done a lot of work around this on glyphosate. It's envisaged that almost every American will eat their body weight per year in glyphosate from this insecticide. And glyphosate pretty well inhibits our phase 2 liver detoxification. So even without genetic SNPs, we have to consider that most of our patients are probably hugely compromised when it comes to phase 2 detoxification. And I think now pretty much we have to be supporting our phase 1, phase 2 detoxification capacities in every single patient, not just patients with genetic mutations or polymorphisms.
Can I add on the glyphosate issue, because I talked to Stephanie Seneff quite a bit. Me and her are working together on some certain genes. I've been giving her some information on them, doing this study, and me and Cynthia getting this compendium out. And glyphosate turns into glyoxylate in the body. So when you have the people with pyroluria or oxalate issues, that could be a big problem.
Yeah.
Huge.
Yeah, good point. Yeah. And maybe that's why we're seeing a lot of oxalate issues as well.
And pyroluria.
Yeah, yeah.
Anxiety, yep.
Okay, well, there aren't any more questions coming through. we're just going to close off now. So if you do have any last minute questions, just quickly fire those through for us. I'd just like to say thank you very much to everybody for showing up today. I hope that you found this information incredibly useful. I want to say thank you also to Cynthia Smith, Sterling Hill and Carolyn Nadowski for presenting this research. And remember that the next webinar, which is Yeast, Alcohol and Alzheimer's, is on the 15th of October, 7:30 for the US, and the 16th of October, 11:30 for Australia. So remember to sign into that nice and early as well. And so I just want to say thank you very much to all of you. Thank you to everyone for coming along.